everybody. My name is Michelle Sharkey and I'm the Chief Executive Officer of the Stroke Recovery Association. And this afternoon I'm going to be talking to you about stroke, what it is, a recap on the types of stroke and how a stroke occurs. I'm also going to be talking about medical care post-stroke. I'm also then going to go on to talk about the importance of ongoing medication, exercise and diet. And then I'll give you some final tips and takeaways to take with you as you go back into the community. Okay. So the first thing I want to say to people is that every stroke is different. And that's because each and every one of us is different and our brains are quite different and we're all wired quite differently. And where the stroke occurs in the brain basically is an indication of how you're going to be affected by your stroke. The other thing is that we have different reactions to stroke. So the individual reaction to a stroke is just as important as the type of stroke that you have and where it occurs. And the other matter that I want to talk to people about is that sometimes talking about stroke and the implications of it can be quite harrowing for people, particularly if they've had a stroke. But it's also important to remember that recovery is ongoing. And medical progress in the last 25 years has been absolutely enormous. And I'm expecting that that will continue going forward so that there's much more hope available to each and every one of you who have had a stroke or may have a stroke in the future. So the incidence of stroke, because it's quite a significant disease. So every 9 minutes in Australia, someone will have a stroke. Over a 12-month period, there are approximately 60,000 Australians who have a stroke or experience a stroke. 70% of those are their first ever stroke. 50% of all strokes occur over the age of 75, but that means that 50% of those occur to people under the age of 75. And in this day and age, being under the age of 75 is certainly not old. And in some cases, even being over the age of 75 is not considered old. Stroke results in 25% of all chronic disability that are treated in New South Wales hospitals. And the statistics indicate that about 25% of stroke will die within the first month. It is one of the greatest killers, or the second greatest killer after coronary heart disease. And it is the leading cause of long-term disability in elderly Australians. So, just what is a stroke? A lot of people think that a stroke has something to do with the heart. Love that bit. However, it has very little to do with the heart. The only thing that the heart and the brain have in common with each other is that they both form part of our cardiovascular system, and what affects our heart is going to affect our brain. But a stroke occurs in the brain, not the heart. And it occurs generally without any warning. So mostly with a heart attack, there'll be pain associated with it, but with a stroke, often, and more often than not, there is no pain attached to it. And the person who's experiencing the stroke may not realise they're even having a stroke. Where someone who's having a heart attack will certainly realise they're having a heart attack. So the medical definition of stroke is that a stroke occurs when blood flow to a part of your brain is stopped, either by a blockage or a rupture of a blood vessel. This results in a sudden neurological deficit which affects the motor, cognitive, communication, and/or sensory components of brain function. So a stroke occurs. A stroke is classified when the symptoms of that stroke last longer than 24 hours, or the symptoms of that blockage last longer than 24 hours. If that blockage or rupture of the blood vessel resolves or goes away within that 24-hour period, it is called a TIA, or a transient ischemic attack. Transient because it's come and gone, ischemic because it occurred as a result of a clot usually, and attack means that it's an infarct on your brain. So what exactly does that mean? So it means that a stroke occurs when there is a sudden complete or partial blockage of an area of the brain or a vessel in the brain. It's usually an artery, but it can occur in a vein, which is much more rare. And these arteries and veins supply blood supply to any area of the brain. And as a result of that interruption of blood supply, brain damage, brain tissue begins to die, and it begins to die very quickly. And without early medical intervention, this damage can be permanent. And that basically means that the sooner you get to hospital, the better. Okay? So there are types of stroke. So the arteries, and I'm going to use arteries mainly because that's the main type of stroke that occurs. The arteries which supply the brain with blood can be affected in two main ways. There can be a clot in the blood, and that can block the artery, and that's called an ischemic stroke. And that's what I call a damming stroke because it basically blocks the arteries. So it's a dam, okay? And an artery can also bleed or burst. And that's what I call a hemorrhagic stroke, or that's a hemorrhagic stroke. And that's what I call a flooding type stroke, because once that artery bursts, blood supply flows out into areas of the brain that it wouldn't normally be flowing into, and it causes damage to the brain because it's not flowing in the normal tributary of the brain that takes blood to the brain and brings blood away from the brain. Okay, so 85% of all strokes are ischemic stroke, and that is that clotting or damming type stroke. And there are three main causes. They're caused by an embolus, a thrombosis, or a hypoxia. An embolus is a buildup of that yellow plaquey stuff that you see that is pushed out in that smoking ad. They don't show it as much anymore, but that's that plaque that builds up on the internal artery of the internal vessels of the artery. A thrombosis is a blood clot, and that can occur anywhere in the body. And a hypoxia is when the brain is starved of oxygen for any particular reason. And that can be caused by a situation when you're having a operation and the anaesthetic isn't being fed through at an appropriate level, or you have sunstroke and therefore your oxygen level in your brain goes down. And the other main way that is caused is by the bends. When you go down too fast and you come up, and air pockets basically form in the brain and are like a little clot, but they're basically a blockage. They form a blockage. Now, the reality is it may not be one or other. It may be a combination of those three, but they basically make up 85% of all strokes. And all of those embolus and clot and hypoxia can occur or start in some place in the body, but it's when it goes to the brain that it causes problems and basically causes a stroke. Okay. So this is what a blockage of an artery or an infarction looks like. And you can see, if you have a look at that little area which has got the little picture cut out, that's a combination of a blood clot and an embolus. Okay, so you can see the buildup of the yellow plaquey stuff as well as the blood clot. Now, where that clot occurs in the brain is going to have an impact on how you're affected by your stroke. So if you were to have a stroke in what I call the fine tributaries of the brain, and I don't know if you can see my cursor, but I'm going to put it up there, in the fine tributaries of the brain, that would probably be a smaller stroke, but it would still have some form of impact on you because it's not going to be taking out very much of the tissue around that area. However, if you were to have a stroke in this area where the circle is, you can see that is going to be a large blockage, and that's going to take out the tributary or the blood supply to quite a significant area of brain. And so that's going to be a significant stroke. But if you were to have a stroke in the three main arteries which supply the blood to the brain, and that is your brain stem, which is the one in the middle, and your two carotid arteries, now that's going to be a significant stroke, okay? And that's likely to result in significant disability and often is the one that's more likely to cause death, okay, or people to die from it. Okay. So the hemorrhagic stroke, there are two main types of hemorrhagic stroke, and they can be caused by a number of things. So there's an intracerebral hemorrhage, and that is the bleeding that occurs inside the brain, and this is the most common type of hemorrhagic stroke. So that's within the actual brain itself. Or a subarachnoid hemorrhage, and that's the bleeding that occurs between the brain and the membranes that cover the brain. And I've got something here that shows you that is hemorrhagic strokes may make up approximately 10% of stroke, and the incidence of cerebral hemorrhage, intracerebral hemorrhage, is twice as common as subarachnoid hemorrhage. And an intracerebral hemorrhage is a very significant stroke. Now, the difference between a clotting type stroke and a hemorrhagic type stroke is there's quite a number of differences, but the main one is with a clotting type stroke, you will often have the clot and the symptoms will come on immediately and you know what's going on. However, with a hemorrhagic type stroke, they can occur very slowly and build up, and the intracerebral and the subarachnoid hemorrhage are the ones that are likely to have pain associated with them, and they are likely to be headache, and they're also likely to have significant feelings of unwell, and you're more likely to be throwing up and that sort of thing with a cerebral hemorrhage. However, one of the things about a cerebral hemorrhage is they may the outcome of a cerebral hemorrhage may take longer to occur. However, it's likely that ultimately the same outcomes occur for both a clotting type stroke and a bleeding type stroke. Okay, got to keep moving you. So this gives you the same picture, but it shows you an intracerebral hemorrhage, and you can see there that the bleeding is in the brain, and it's quite a significant area of brain that the blood has taken over. And what happens with a bleeding type stroke is that blood is being pumped up into the brain, and the brain through the arteries, but the arteries are not able to then continue to pump the blood away because it's not going through the normal tributary that it would normally follow. So basically blood begins to fill the space inside the brain, and that causes significant swelling of the brain. Okay, now I'm going to show you how quickly a stroke occurs. So I want you to have a look at up here in the corner. I've got time of onset of stroke, and that is the number of hours. And then watch the little area in the middle of the brain as the stroke occurs. I hope this works. Okay, so that yellow area is area of brain that is called the penumbra. Uh-oh, this isn't going to work. And basically what that means is that that's area of brain that can be saved if intervention occurs. But as the stroke extends and the time gets longer, basically, sorry, I've got to go back. Basically, how do I go back? Yep, there you go. Basically, that's a very large area of brain that's been affected by the stroke. So you can see that within 6 hours, significant damage has been done to that area of the brain. Now, that can occur any area in the brain. It doesn't occur where that one's placed, but it does show you how quickly a stroke occurs and how quickly the impact of a stroke is going to have a significant impact on somebody's long-term outcome and life and quality of life. Okay, so the signs and symptoms of stroke, and you all know them. So just to go into them a little bit more clearly so that you understand them, a stroke occurs on one side or other of the body generally. Okay, so you're likely to have a stroke that occurs in the right-hand side of your brain that affects the left-hand side of your body, or vice versa. You can have a stroke on the left-hand side of your brain and it's going to affect the right-hand side of your body. And generally that's how stroke occurs. If you have a major brainstem stroke that you survive, then that may result in what they call locked-in syndrome, which basically affects both sides of your body. So both sides of your body can be affected. However, so the main symptom of stroke that we all know and understand is that hemiplegia, when basically the message from the brain to the muscles and the functioning of our legs, arms and face are no longer getting through, and basically the muscles stop working, and our ability to use our arms, our legs and our facial muscles basically stops. Okay, so that's the main one that everybody can recognize as a stroke. However, there are others too that are significantly important. So confusion, by confusion, I mean that you don't know where you are, who you are, the time, the date and the place. And it's why when you go into a hospital having had a stroke, that the nurses and doctors are always asking you to clarify who you are, what your date of birth is, and who the Prime Minister is generally. So always practice up on those things. So what they're doing is they're checking to see whether or not your symptoms are getting worse or whether or not they're resolving. Okay, so that's why they're testing confusion all the time. But confusion is one of those ones that you yourself don't often see if you're having a stroke, but somebody with you will recognize that. The weakness of the arm, the leg and the hemiplegia is likely to be recognised by yourself because it's likely to result in some form of fall or some form of inability to function doing what you were doing prior to having had the stroke. With the facial weakness, it basically means that the muscles in one side or other of the face stop functioning. And there are enormous amounts of muscles in our face and particularly in our throat. And so when they stop functioning, other people can notice that, possibly a lot faster than we can. But it doesn't have to be a complete stoppage of those things. It may be that it can be a feeling that you receive. It might be a numbness, so you can't feel your face, or your face feels numb, and when you smile, it doesn't feel right. Or it may be that you get pins and needles, and that can occur again in any part of your body, left or right. And it's a very strong type of pins and needles. So, you know, when you wake up and you've slept on your arm and you rub your arm and the pins and needles go away, or what you'll find if you're having a stroke is the pins and needles will not go away, that feeling will stay there for some time. Now, the other significant indication that you're having a stroke is speech deficits. So your speech changes. So that can be expressive, your ability to get your message out and say a sentence or talk to somebody clearly and coherently, or it may be your ability to receive a message. So to understand what somebody's saying to you and to be able to process the instruction that they're giving you, or to just understand enough to respond to what they're saying. And the thing with speech deficits is that it could also be both. And one of the things that I didn't mention at the beginning of this is that all stroke symptoms are on a continuum from very mild to very severe. Okay, so all of these can come on anywhere along that perimeter. And the other thing is with signs and symptoms of stroke is you may experience all of those, or you may only experience one. And that then becomes a real difficulty for people to then be able to say, well, yes, I need to get medical attention. But certainly speech deficits are the ones that can be recognised very, very quickly, along with that hemiplegia. The other one is visual deficits. And visual deficits, again, are quite significant and are often described by stroke survivors as a warning sign that they received previously, but they didn't pick up on it. Now, remembering that a stroke affects everything that we think, we feel, we say, and we can do. And so it can affect any aspect of your vision. It can affect your ability to see out of your one eye or other eye. It can affect your ability to see either up the top hemisphere of your eye or the bottom hemisphere of your eye. It may even impact just 1/4 of your eye, or it may also come out that your vision is just a pinprick in the middle. And the other thing that stroke survivors often talk about is that veil coming down so that your vision is often blurred, and it may also be what they call ataxic, which is where it's jumping up and down and you can't control that. And that makes vision very difficult to see. Now, the other thing is swallowing problems. And we have an enormous amount of muscles in our throat, and these affect our ability to speak and to form words, but they also affect our ability to eat and to drink. And one of the things that should occur within 24 hours of you going into hospital, no matter what type of stroke you've had, whether it's severe or mild, is there should be a swallowing assessment done so that the speech pathologist can see whether or not you're being able to get your food down the right channel that it's supposed to be going down. Because one of the significant reasons that people passed away from with stroke in prior years was aspiration pneumonia. And it's one of the reasons that more people are living well after stroke, in that swallowing problems are now treated as a priority as well. So they're the main symptoms of stroke. However, when you're in the community, one of the things the National Stroke Foundation does is ask that everybody have the simple FAST test. And it's simple and it's easy for people to understand. So basically, face, you ask the person to smile, then you ask the question, is their smile crooked? Can you detect from their smile some drooping of their mouth or their face? Okay, and it's easy to detect if somebody's having a stroke. A stands for arm. Ask the person to raise their arms above their head. If they are able to do that in unison, so together, or they are understanding, or they can get it to a certain level together, or is one arm drooping behind the other, or on one side or the other. And when they're doing that, is the person aware that their arm isn't moving at the same pace or in unison with the other? And the speech is really quite difficult but simple at the same time. So you ask their person to repeat a simple sentence, and you're now looking to see a few things. You're looking to see, do they understand and can they comprehend the instruction that you've given? Is their response to you making sense? So are the words and the flow of their response making sense? Are they having difficulty finding or expressing words? So you ask somebody to ask a simple sentence, repeat a simple sentence. My name is Michelle Sharkey and I work at Stroke Recovery. I hope that came out clearly. For somebody who's been asked to repeat that, they may give you a blank look because they're not comprehending that you've asked them to repeat the simple sentence. They may try to respond to you, but the words may not come out. It may come out in what is called effortful speech, and that is or it may mean that I can't get the words out altogether. And the other thing it may be is that I only go for big words. I might say Michelle Sharkey stroke. Okay, so I'm only picking the words at random to respond to you. And the other thing that can happen with difficulty in getting words out is that they may think they're saying the sentence to you, but the sentence comes out all jumbled and it doesn't make sense. Now, the other thing that can happen with speech is that people can lose their whole ability to both either comprehend the instruction or to even respond to you, because all aspects of speech are affected. So as I said to you earlier, it's that continuum from very mild symptoms to very extreme. And not that many people have the very extreme speech difficulty, however, some do. And often it's really very difficult for their family to understand what's happened and why and how it's occurred so quickly. And the T is for time. So going back to remembering that a lot of damage can be done in that 6 hours. And so we need people to be seeking medical treatment as soon as possible. And as soon as any symptoms of stroke are detected, you need to ring 000. And that is the biggest message that I've got today. So even if you think you're having a stroke, you ring 000. Okay. Now, why ring 000 and not go to a hospital on your own? Well, the main reason for that these days is because once you ring 000 and you say somebody is having a stroke, then that becomes a medical emergency. And that medical emergency means that the ambulance is dispatched quickly and efficiently, and it basically should get to the patient within a very short period of time, because time is of the essence. And in New South Wales, we have a requirement for stroke treatment to stroke patients to receive priority from ambulance, and they need to get to the patient very quickly. And once they get to that patient, they start assessing the patient. And it's that assessment that's really important, because not only will they start assessing the patient as to the fact they've had a stroke, they can also start looking at issues to see what type of stroke they've had. They will then ring ahead and they will prepare the stroke team at the stroke unit to receive the patient. Now, the other thing they're going to do is they're going to start treatment. Okay, so they will start treatment with things like they will start assessing using blood pressure. They will also apply oxygen, and they will apply high level oxygen in the hope that if it's an hemorrhagic, an ischemic type stroke, that they can then push the clot through so that less damage occurs. And I've got the Emergency Plus app up there because everybody should download the Emergency Plus app to their phone. And the Emergency Plus app is an app has been developed by paramedics in New South Wales. And basically what it can do is it can locate you within 20 metres of where you are experiencing your medical incident. Okay. And you can then also identify, because I'll always ask you, what's your nearest cross street? And I don't know about anybody else in emergency, but I always forget what my nearest cross street is. And that will be able to give you an indication of what your nearest cross street is. Okay. The other thing they are going to do is they're going to go to your nearest hospital with a stroke unit, and they're going to assess the level of the stroke to see whether or not there needs to be bypass put in operation. And again, within New South Wales, we have different types of stroke units. And so the ambulances in discussion with either the stroke unit themselves or with the ambulance headquarters will determine your nearest hospital, so that time is a priority. But if they think that you're going to need greater treatment than what you're going to get in a smaller hospital, they will then look to bypass that so they're not wasting time, and they will go to a hospital that has much more resources to be able to treat a more significant stroke quickly. Okay. So the treatment for ischemic stroke and hemorrhagic stroke is quite different. In New South Wales, in the last 10 years, they've instigated telestroke sites in 23 in situs throughout New South Wales. So the rule within New South Wales is that you should not be any more than an hour to an hour and a half away from the ability to receive stroke treatment. And that is from the time that the call is received to the time that you hit hospital. It's a little over the top, and sometimes I think in out of Western New South Wales, it's never going to be reached, but that's their aim. Okay. And then what they want you to do is to get to either a stroke unit or what they call a stroke service. So if you're in rural New South Wales, they will take you to one of the telestroke sites, and there are 23 of them. They were initiated on the New South Wales North Coast at Taree some years ago, and now that program has been rolled out to 23 sites. So most of you online today would live within an hour of a telestroke site or within an hour of a stroke unit. So why a stroke unit and why is it so important? Well, it comes down to a couple of things, and not only just medical. It's basically now a high dependency unit. In other words, it's a specific ICU, intensive care unit, where stroke is treated. And it's treated by medical professionals who are trained to basically recognise and treat the symptoms of stroke. And that is not only doctors, but it actually comes down to both the nursing staff, who are quite specialised in those areas, but also the allied health professionals. So the aim of the game is to, 1, save your life, 2, identify the type of stroke that you've had so they can give you the appropriate medical intervention, and 3, to get you back on your feet as fast as possible. So what type of treatment are you going to get if you go into a stroke unit within New South Wales? First of all, they're going to determine the type of stroke. So is it an ischemic stroke or is it a hemorrhagic stroke? Because an ischemic stroke and a hemorrhagic stroke are quite different, and the treatment for one is contraindicated in the treatment of the other. So what I mean by that is, if you have an ischemic stroke, they're going to be looking to basically get rid of that clot and basically thin your blood down, and with a hemorrhagic stroke, they're looking at slowing your blood down, okay, so that your blood is not flowing as quickly. So if you have an ischemic stroke, there are a number of things that are available to you in New South Wales. They have what is called clot-busting drugs, or TPA. And that basically is a type of drug that they can insert. It somehow miraculously, and I'm not a doctor, so I'm not quite sure how it does this, but it basically weaves its way through your arteries up to your brain, and it basically bursts open that stroke or that clot to basically reperfuse or reopen the blood supply going through that artery. So that's the first thing they're going to try. If you have a significant stroke in one of the larger vessels of your brain, you may also be eligible for what is called endovascular clot retrieval. And that can be done in a comprehensive stroke unit. That will be done under the care and guidance of both the neurological team, but an interventional radiologist as well. And what they do with that is they insert a catheter type thing through your groin and weave it up through your artery to your brain. They basically insert the catheter like a corkscrew into the clot. They twist it, they remove it or suck it out, and basically drag it out through the groin. Now, the trick with that is, again, to reperfuse or reopen blood supply to the body, to the brain. And the faster you get either TPA or endovascular clot retrieval, the faster the brain is going to start to basically heal itself. Okay, and both of those treatments have come into New South Wales in the past 10 years, and they're quite significantly better at it. However, it's very unlikely, if you are, say, in Port Macquarie, that you're going to get endovascular clot retrieval. If you will get TPA administered through the stroke team on telestroke at your 23 sites, they will certainly administer the clot-busting drugs. But if you were to need endovascular clot retrieval, you would be sent to one of the major clot retrieval centres. And within New South Wales, at this time, there are 5. And they include RPA, John Hunter, Royal North Shore, Newcastle, and I'm going to remember the other one in a minute. I think it might be St George, but don't hold me to that. But they're the main ones that you're going to get endovascular clot retrieval at. If you live on the coast, as I know you do, Andy, if you were to have a major clot there that required some form of endovascular clot retrieval, it is more likely that you would go across the border to Queensland, because they have New South Wales has an agreement with basically Queensland to treat those more significant strokes there. Okay. Now, hemorrhagic stroke. Now, hemorrhagic stroke is one of those things that up until recently hasn't had any major intervention or a stroke pathway. They've just introduced a stroke pathway for a hemorrhagic stroke. It doesn't mean they weren't being treated. It just means they now have a much more organised approach to hemorrhagic strokes when somebody has one and comes in to a stroke unit. And the reason they're doing this is basically because there's again been advances in stroke treatment and there's been a lot more research done. So now if you were to go into a stroke unit and having had a hemorrhagic stroke, you would receive options of 3 types of treatment. The first one is that they would use reverse anticoagulant drugs. Okay, so if you were to go into a stroke unit having an ischemic stroke, you would be given TPA, which is basically one that is an anticoagulant. So it stops your blood from clotting. But with a hemorrhagic stroke, an anticoagulant drug basically does the reverse of that. It thins your blood so that it thickens your blood. And if you have been taking any anticoagulants, which a lot of people do as they get older, and by that I mean high-level aspirin and others that you may be placed on by your medical doctor, they will now try to thicken the blood to slow the blood flow down. They'll also lower your temperature and make sure that, and also actively work to lower your blood pressure. And those are the 2 things they work actively to lower. The other thing is they will then have a discussion with basically a neurosurgical team to see whether or not there is any requirement for surgical intervention. And that may be that to clip an aneurysm of some description, to put in a stent of some description if there's that ability, if the artery has burst, or it may be to do 2 other, which I think are a little bit more significant interventions. And the first one is burr holes, which is where they basically bore holes into your skull to allow the pressure of the build-up from the bleed to go and be relieved. And the other one is a craniectomy. And what that is when they take out a flap of your skull and they basically preserve that flap of skull and they make sure they've got it in a safe place and a cool place so that it doesn't die. And then what they do is they allow the brain to swell. And when that happens, there's less damage happening to the brain. Okay, so they're the main things that they're now looking at in terms of treating hemorrhagic strokes. And hemorrhagic strokes are the ones that occur more often and at a greater number in younger stroke survivors. So they're now putting a lot more effort into ensuring that stroke survivors have a much better quality of life. There are also strokes that can often lead to more significant issues for people and certainly disabilities for people post-stroke. Okay. So the main message here is that no matter what level of stroke you have, from a very mild stroke to a very significant stroke, medical assessment, treatment and intervention is essential. So if you were to have a very mild stroke and go to your GP and he was to say to you, you've just had a funny turn or you've just had a mild stroke, that doesn't stop there, or it shouldn't stop there. There should always be an assessment and by that I mean a further assessment to find out what type of stroke it was, where it occurred in your brain, and again to see the area of brain that's been affected to give you information about the likely effects that it's going to have on your life. There should also be some form of ongoing treatment. So if you've had a stroke of any description, there should be some form of ongoing treatment with drugs and ongoing drugs, maybe aspirin or some form of blood pressure medication. It often comes down to those sort of things, which I'll go into a little bit more later. But there has to be some intervention. You don't just accept these days that you've had a funny turn or you've had a mild stroke and there's no further assessment of that. It is always important to follow that up. And you also follow it up to make sure that you know what's going on with your stroke, okay? So just going through one of the risk factors for stroke. Now, remember, stroke can occur anytime, any place, anywhere. And you can do everything right in life and never have a stroke. And you can do everything wrong in life and never have a stroke. Or you can do everything right and have a stroke, or you can do everything wrong and have a stroke. So there's often very little explanation as to why you've had the stroke. And you can often, and I know there is that whole thing that 80% of strokes can be prevented, and there is merit to that. However, if we could have prevented our stroke, I don't think there's anyone in this world who wouldn't have taken steps to prevent it. The problem is we need to get that prevention message out there. So let's look at your risk factors, because there are some risk factors you can do something about and some risk factors that you can't do anything about. So the ones that you can't do anything about are two, and they're very simple. Age. As we get older, our risk of stroke increases. And that's basically because our bodies start to wear out, and in particular, our cardiovascular system starts to wear out. Okay? And no matter what we do, that's going to occur. Okay? But healthy aging is a really important thing to do. Family history is something else we can't do anything about. Okay? And if you have a family history of stroke, you need to be quite mindful of the fact that there may be some genetic component to it that was never picked up when your mum or dad had a stroke. And it is something to always be on the lookout for. And I always use my family history as an example. My dad had his first stroke at 19, his second stroke at 27, and the one he died from at 33. When Lachlan was 19, he had what I perceived at the time to be a major stroke, having visual issues, vomiting, all the things which were part of a hemorrhagic stroke or symptoms of a hemorrhagic stroke, which is what my dad died of. So it was essential to get him to medical treatment very, very quickly. He didn't have a hemorrhagic stroke, but he had what they explained to me was a silent migraine. However, migraines are something that we don't ignore anyway. So he's now under treatment for that. So family history is important. Look at your family history, pay attention to it. There are others that we can do something about. And the greatest cause of stroke is hypertension or high blood pressure. Okay? And that is something that can be very easily controlled and very easily assessed and treated. Okay? So whenever you go to a doctor, you have your blood pressure taken and you make sure you know what your numbers are. There are other health-related conditions. Being overweight is another issue to do with stroke. Heart disease is another risk factor for stroke, and diabetes is another risk factor for stroke. And heart disease, the main issue for heart disease, or the main significant connection between heart disease and stroke, is a condition called atrial fibrillation. And that's when the heart starts to malfunction in some way. It may be an electrical malfunction or it may be a physical malfunction, but whatever it is, it basically causes the rhythm of the brain to basically go out of whack, and it needs to be brought back into sinus rhythm. And if treated appropriately, atrial fibrillation can be basically controlled and maintained. So it's important all the time to have these things checked and rechecked when you go to the doctor, no matter how old you are. And the other one is diabetes. So diabetes is one of those issues that is significantly associated with stroke because our blood carries a lot of sugar. And when we basically have diabetes, it means that our bodies cannot process sugar properly. And when we are not maintaining our diabetic level at the appropriate level, our blood thickens. And when our blood thickens is when we are at most risk of having a clot form, and therefore a stroke can come from that. Smoking is another one that is quite significantly associated with stroke for a number of reasons. One, it weakens the arteries in our brains. The other thing too is it basically takes oxygen out of our blood. And when we take the oxygen out of our blood, it means our blood starts to thicken. So with smoking, I don't just mean cigarette smoking, I mean vaping. I also mean marijuana smoking. And I also mean that I think it's called shishi smoking, which is what a lot of non-English speaking background communities are very prone to. Okay, so remembering there are some things we can't do about having a stroke, but there are significantly some things we can do, and we need to give ourselves the best chance of never having a stroke. So making sure that we are going to a doctor regularly and having all of those issues checked. So preventing a stroke, okay, preventing a stroke, and I'll go into these a little bit more in detail, but this is just our prevention brochure that we put up, basically because it is a very simple way of getting the message across about having a stroke. And the one that I wanted to talk about there was to never ignore the warning signs of stroke, because doctors will say to me they want people to get to hospital and they send them home well if they get there quickly, rather than them sitting at home and the stroke gets worse or extends. And by the time they get to the hospital, it's well past the time that the doctor can treat them. And the other one there, which we very rarely talk about, is take your medications as prescribed by the doctor. But I will go into these just a little bit more. So post-stroke, it's important to understand your stroke. Know the type of stroke you had, understand what caused your stroke. Ensure you have a good GP. If you don't, change it. The other person who's vital in your stroke treatment is a good pharmacist and somebody who can sit with you and explain your medications and the likely side effects of those medications. And they're also good at picking up if the doctor is over-prescribing in areas, and they will often pick that up when you take in another script, and they will ring the GP just to check what's going on. It's also important that you have a treatment plan with your GP once you go home, and therefore you follow that treatment plan and you go to see your GP regularly. If you have any specialist follow-up, and it's highly unlikely that you have follow-up with your neurologist, but you may, but certainly do if you do. It's always good to follow up with a neurologist. However, the other ones that are really important to follow up with are things like basically the doctor that's treating your heart, and also anyone who may be treating diabetes, and to making sure that all your specialists are talking to each other and knows the medications you're on. And my other thing in terms of your medical care post-stroke is ask questions until you understand, and as importantly, that your carer or significant other understands, so that you're all involved in your post-stroke care. Understand the treatment, know your numbers, know your blood pressure, know your cholesterol level, and look at what's important. And ask your neurologist what numbers they're expecting your blood pressure to be. Ask your doctor and your neurologist what level they want your cholesterol levels to be. It's important that you know that and you know the range that you're in. Blood pressure, they generally want your blood pressure. Heart specialists say 140 over 90 or under that. Neurologists will say 135 over 90 or under that, okay? Cholesterol level, both your good and bad cholesterol, basically 3.5 to 4.5 is as high as you should go. and particularly be under the care of a good heart specialist if you've got a significant issue with cholesterol. Managing any risk factors is important. So following your treatment plan, following anything you need to be following with any forms of heart disease, diabetes, and if overweight, okay? The type of stroke that determines the type of stroke you've had determines the medications that you may be prescribed. So if you've had an ischemic stroke, it's likely that you'll be on some form of blood thinner, blood pressure medication, cholesterol medications, and by that I mean statins. You may be on antidepressants, but it's important to review your medications annually. Have a list of your medications, but every year get a plastic bag, take your medications, all of them, into your GP and say, tell me why I'm on these, and review my medications, okay? And if you're not going to your GP to do that also with a heart specialist. And if your doctor is taking you off one medication and putting you on another, you need to know whether or not he's doing that as an adjunct to the first one or in addition to the first medication, or whether he's actually removing one medication and putting you on a different medication, because that's one of the really crucial issues these days. The other thing to remember is that using complementary medications may influence the medications that you're on through your GP or your specialist. And by that, I mean that we're on a number of complementary medications because we're often being told we're not getting enough vitamins and minerals. So a lot of us are on things like vitamins A, B, E, etc., fish oils, okay? And also a lot of people are now getting into Chinese medicines. Now, one of the things to remember is that Chinese medicines in particular are blood thinners. So if you're on any complementary medications, you need to be telling your GP about that so that they can see whether or not that's going to impact on the medications and therefore your long-term health with the medications that they have you on, okay? And remember, if you're on any blood thinning medications and you're going in for surgical treatment, have a chat to your surgeon about when you need to stop those blood thinning medications prior to going into surgery. And if you're on anything like vitamin E or fish oil, then you have that discussion as well, because they can often impact whether or not the surgery will go ahead. Okay. Diet, healthy eating, alcohol intake, small meals, healthy body weight, okay? So the Heart Foundation really has the best recommendations in this area, okay? Eating fresh foods and less highly processed junk food is always a good start. Foods low in salt, foods low in sugar, complex carbohydrates, but again in moderation, everything again in moderation. Alcohol in particular, in moderation. And remember, alcohol may also increase the effects on your body that the stroke has left you with. So for a woman, no more than 1 standard drink per day, and for men, no more than 3 standard drinks per day. Okay, and I also always say red wine is better than white wine is better than spirits. Spirits are not the main issue, it's the additives that you put in the spirits, which often are very high in sugar. So you need to be watching that all the time. Maintaining a healthy body weight is a really crucial thing for our health. Moving more and eating better is really important in having a healthy weight. So trying to get up and move every hour is essential, says us, who's been sitting here for well over an hour. But moving every day and going for as much of a walk as you can. And even if you are in a wheelchair, trying to do some chair exercises, which will get the blood flowing, okay? Learn how to measure, I've got to move you again. Learn how to measure your waist to tell if you're on a healthy weight. And this kills me, I have to say to you, because I thought I was doing really, really well because I got my circumference of my waist under 90 centimetres. However, they're now saying that it's 94 centimetres for men and 80 centimetres for women. much more easily maintained in premenopausal women than it is for those of us who are in postmenopause. Okay. Exercise, regular exercise is important. It impacts your blood pressure. It can reduce blood pressure. It reduces cholesterol. It certainly impacts being overweight. And it helps strengthen your bones and muscles, and it can make you feel more energetic. And it also impacts your mood. Okay. Start small. Remember, every step counts. So start off just walking around the back room and then trying to build it up from there. Set realistic goals and be kind to yourself. Get more active in your neighbourhood. Go for a walk. Get to know your neighbours. My son says I speak to too many people these days because I walk around the neighbourhood. Okay, and people chat. Mix up your activities. Get a bit of variety so that you're using different muscles. And some of the things that you can add variety is try Tai Chi. It's really good, and you can do Tai Chi in your chair. Chair yoga is important, and a lot of these we always have on our YouTube channel that you can do, that we've had at conferences, or we've had Topical Tuesday or Thursday speakers on as well, and they're there for you to follow. Be prepared, dress for weather, be sun smart. Okay. Make sure you're safe. That's essential if you've had a stroke. And as we get older, it's really important to make sure that where we walk and when we walk is very safe, because falls are a big issue for people as we get older. Get active with friends and family. So if you do it with other people, it's more likely that you're going to go. If you're going to go swimming, have a friend who goes swimming with, and then if they pick you up, you're going to be at the door waiting for them instead of giving yourself a reason as to not go that night. Okay. So types of exercise which are really good. Tai Chi. Okay. Again, Tai Chi is one of those things that move the energy to both sides of your body. And it's a really good brain exercise as well as a flowing body exercise. Swimming or aqua, you know me, that's my major activity and I love it. It's really important. Okay, and the other thing it is it's safe. So getting into a pool, for anybody who has mobility issues or balance issues, it's much easier and safer to do your exercise in a pool. Chair exercises, be seated. Sit to stands. How many of us have done a million sit to stands because physiotherapists say sit to stands are the most important thing we'll ever do? You know, set yourself a goal of sit to stands and use your muscles in your tummy appropriately, and make sure you've got the correct chair to do it in and you've got your correct stance to sit it in. A standing cycle, or one that just basically stays in the same spot and you can sit on it and cycle, is also a really good exercise, and it's safe as long as you've got someone to help you get on and help you get off. Weights are essential as we get older to build body strength, so remember that's important. And the other thing is, remember our brain training. Use apps on your phone to do Sudoku, to do I'm playing, solitaire, euchre, those sort of games on your phone, which are really easy to download and easy to at least get your brain flowing and giving you some brain exercise every day. And don't forget our brain training sessions every month as well, because they're really important. And the other thing too is basically getting out and doing some of these things with friends. So going to a trivia evening or a trivia lunch, all of that stuff is really important. Okay. My final tips and takeaway. Okay. Prevention is the key to either an initial stroke or a secondary stroke. Always be essential. Always be prepared for the fact that you may have a stroke. Medical intervention is essential. Don't think it's going to go away. Go and get some assessment, intervention and treatment. If you've had one stroke, always be prepared. It doesn't mean you're immune from another. Know your stroke. Knowledge is the key. Be in control of your own health and take responsibility for it. Follow-up medical care is essential. Really, A good GP is worth their weight in gold. And if you don't have one, and one who's prepared to give you time and who listens to you, keep looking around until you get one. Get to know your pharmacist. Really, they're fabulous. Okay, and they always keep, if you get to know your pharmacist, they will keep an eye on your health. If you need a specialist, see them regularly. If you think you need a specialist, but your GP won't refer you to a specialist, argue the point. Again, you're in control of your health. Make sure that you're feeling comfortable with where you're at in relation to your health. Health and well-being, exercise regularly, do what you can do. Something is better than nothing, and get up and move. And if you do nothing else during the day, go outside and get a little bit of sun, because sun lifts mood, okay? And get outside and feel the sun on your face and the grass on your feet. Diet is important. Go to the Heart Foundation website. They really have great tips and recipes. And the other thing is socialise regularly. And even if that means going down the road talking to random strangers, go down the road and talk to random strangers. It's amazing how that can build up a sense of community very, very quickly. And the other reason to do that, particularly if you live alone, is that then people are keeping an eye out for you. And if you don't show up, then there is that regular thing of saying, oh, where's Michelle? Why didn't she walk Bailey this morning? Or something along those lines, okay? So be prepared to put yourself out and socialise regularly. And that's also why stroke support groups are so important for those people post-stroke. But even pre-stroke, make sure you are joining some form of socialisation community, particularly as we get older. Isolation breeds depression, and we need to make sure that none of us fall into that. And I think that is my final slide. So what do I think if I'm having another stroke? It's the same message. Stroke is a medical emergency. Call 000. Use the Medical Emergency Plus app. If you don't already have an alert device, get one. It's essential, particularly if you live alone. One of the great alert devices that people have now are basically on your watch. So make sure you have that if you can afford it. I'm not advertising the brand, but there is one brand that does have an alert device where you can notify your children or some significant other that you may need assistance. And the other thing is, make sure whenever you have a stroke, you go to your nearest hospital with either a stroke service or a stroke unit, so that you can be linked in either by telestroke or by direct action to the experts who are able who are trained to treat stroke efficiently and effectively, and are absolute authorities on what is happening to you in your stroke. Okay, so thank you.